All right, tonight we're going to introduce Dr. Allison Schroeder. She's going to give a tour of tendinopathy with a focus on CAQ-relevant topics. So the point of this lectureship is to serve as an adjunct to your individual program's educational content, provide fellows with direct access to educational experience with AMSSM members, and at times invited guest experts, and also to assist with your CAQ exam preparation. So we ask that you mute your device's microphone and turn off your video. If you have any questions, please put them through the chat and we'll make sure to get through to them. And then also at the end, we'll do some questions with Q&A. And I'll try and address any questions if you need to during we can stop Dr. Schroeder and ask her during it, but if you can, save them to the end. And then at the end, please complete the evaluation. So Dr. Allison Schroeder is part of UH Hospital. I'm very happy to be a partner with her in practice. She's assistant professor at the University Hospitals at Cape Western Reserve in Cleveland, Ohio. She completed her residency in PM&R at the University of Pittsburgh and did her sports medicine fellowship at the Mayo Clinic Square in Minneapolis, Minnesota. She provides medical coverage for the Cleveland Ballet, Baldwin Wallace University, Cleveland Marathon, and several high schools in the Cleveland area. Her clinical and research interests include diagnostic and interventional sports ultrasound education, tendinopathies, and female athletes. I'm very excited to have her join us tonight, and I look forward to this talk. Let me make sure I don't have anything else to share. So if you have any ideas that you would like to give us for topics, please go on the AMSSM website and go under the National Fellow Online Lecture Series and fill out the form. We are always looking for good ideas and making sure that we cover everything that we can. Our goal is to make sure that everything that you need to know for the CAQ, we've covered at some point during a 2-year cycle. It's hard to get everything in 1 year. Also, the primary goal of this lecture is to assist with CAQ preparations. So if you scan this, you can, it'll link you right over to the site to lead you into the AMSSM site. All right, Allison, I'm going to stop my sharing and you can start yours.
All right, let me pull it up. All right. So thank you for the introduction. I titled this presentation A Tour of Tendinopathy. It's somewhat of a challenge. It's a very broad topic. And so if you imagine you're going to a city and you only have a couple of hours to spend there, in our case, 1 hour, we're going to try to hit the highlights of tendinopathy for the CAQ. Each tendinopathy could probably be an hour lecture in and of itself. So there will be a lot of things that I cover very superficially. And again, the goal of this is to hit the high yield stuff. I hope that you can get a couple questions right on the CAQ after this presentation. I don't have any disclosures. So like I said, the goal is to highlight anything related to tendinopathy that's relevant for the CAQ. So in prepping for this, I went to the website that lists everything that you need to know for the CAQ and pulled out relevant pieces. So again, this is still extremely broad and difficult to cover in an hour. The one piece to this that I will highlight is anatomy. A lot of tendinopathy questions may be tied back to anatomy. So they will ask you to know everything about it, figure out what tendon it is, and then they'll ask you the origin or the insertion, or they'll ask you the muscle action. So most of the questions you'll see related to tendinopathy are probably going to be multi-step questions. Our learning objectives, we'll talk about the definition of tendinopathy, a little bit of the basic science. That's something that I think we often skip, and the boards seem to love basic science and physiology, and then high yield topics related to the tendinopathies of the extremities. So definition and tendinopathy basics. So the term tendinopathy is actually a clinical term. The pathology behind tendinopathy is very broad, and that encompasses from tendinitis and tenosynovitis, which are acute inflammation, to more chronic tendinosis, development of calcific tendinosis, and eventually degenerative tearing. So this is a spectrum. Tendinopathy in and of itself is an overuse injury, and clinically it's characterized by pain, decline in function, and reduced exercise tolerance. When we think about the basic science of tendon, normal tendons are made up of type 1 collagen in a proteoglycan matrix with very few fibroblasts. When we have injury and chronic injury and tendinosis, type 1 collagen is replaced with type 3 collagen. Throughout the talk, I have these little red lightning bolts, and those are typical points that seem to be high yield that you may or may not get asked about when you're doing practice questions or on the real CAQ. Tendinosis also has increase in microvasculature, neonerves, and then a dysregulated extracellular matrix. So we're already to the first question. The biomechanical behavior of tendons determines how much normal and abnormal tendons deform under various loads. Which of the following is true regarding the stress-strain curve? A, the linear region of the curve refers to the section of the curve where the tendon fibers are crimped and very little forces are required to straighten or uncrimp the fibers. B, an 8 to 10% strain of tendon is elastic and returns to its original length after a strain of this magnitude. C, the elastic modulus or Young's modulus is the stiffness of the tendon and is measured as the slope of the stress strain curve. Or D, the yield region of the stress strain curve represents tendon failure. And large amounts of stress at this point of the curve produce minimal tendon strain. So many of you are correct. The correct answer is C. The elastic modulus or Young's modulus is the stiffness of the tendon and is measured as the slope of the stress strain curve. So as you can tell from that audience response, the physiology is often a challenging piece when we're thinking about prepping for the CAQ. So here I've corrected the incorrect answers. It's actually the toe region where the tendon fibers are crimped. At less than 4% strain, the tendon is elastic and returns to its original length after strain. That's the linear region. And then the yield of the stress strain curve is, the yield region is where you have tendon failure, but at that point it requires minimal stress. So I always learn better by graphs and pictures. So here's our stress strain curve, strain on the x-axis, stress on the y-axis. The fibers are crimped in the toe region with less than 2%. This linear region is where the fibers straighten. And after 4% is where you start to get microscopic failure. Once we get up to this point, it does not require much additional stress to get a lot of strain, and that's when we can get rupture. And as that answer to the question alluded to, the Young's modulus is the slope of this line, the stress over the strain. All right, one more slide on basic science, and then we'll move into the specifics of different body types. So the other question that you could get related to basic science is about the phases of tendon healing. And typically this is going to be a multi-step process asking you about treatment options for different phases. So the main phases of tendon healing are an inflammatory phase within the first roughly 48 hours, a proliferative phase up until about 6 weeks, and then a remodeling phase after 6 weeks where the type places type 3 collagen and about specific tendinopathies. History point, if you have a clinical vignette, it's probably going to say something related to overuse and development of progressive pain and irritation, usually following an increase in load with a lack of recovery, and there's the presence of risk factors, and these can be highly testable. So intrinsic risk factors are anatomic abnormalities, that's muscle weakness or imbalance, malalignments, decreased flexibility, joint laxity, older age, female gender, higher weight, metabolic conditions or spondyloarthropathy, a family history of tendinopathies or deficits in neuromuscular control. Extrinsic factors have to do with the training load, either frequency, duration, intensity, any errors in training, overtraining, too rapid of a progression, running on hard surfaces, having poor tennis technique, not recovering well, equipment problems with shoe wear or rackets or seat height if you're a cyclist, poor ergonomics at work. And then medications, we commonly think of fluoroquinolones, but hormone replacement therapy and statins are also risk factors. From a physical exam, we all know the basics: inspection, palpation, range of motion, neurologic innervation, and special testing. On inspection, typically you don't see anything abnormal in tendinopathy. Usually they have tenderness to palpation over the involved tendon. You can have pain at end range of motion when you're stretching the tendon, and also have pain and or weakness when testing the strength of the muscle that the tendon attaches to. And some of the special tests related to tendinopathy can be higher yield, and I'll touch on a few of those throughout the talk. From an imaging standpoint for tendinopathy, typically it's not necessary. So if you get a vignette on the exam that is clearly a chronic problem, usually the next step is not MRI unless they've tried multiple other things before that. However, clinically, we often get a lot of imaging. We'll use X-ray to rule out bony pathology. And if you are needing more advanced imaging, diagnostic ultrasound has superior spatial resolution to MRI, which can be an excellent in-clinic tool. And then MRI, especially if you're also looking at the joint or want to see a bigger picture view. And I will also say you will want to get some imaging before you're going to think about doing any type of procedure or referring a patient to a surgeon on your test. From a treatment standpoint, So from a treatment standpoint, this is a stepwise process. On the exam and in clinical practice, we typically start with the least invasive and progress to the most invasive treatments. It's important to remember that complete immobilization of tendons leads to scar formation, and tendons need load to heal. So a common answer is going to be specific rehabilitation for that tendon problem. Again, talking about chronic tendinopathies. There's a separate lecture that covers a lot of the treatments in depth. I'm going to hit the surface of the treatment because on the CAQ, the questions that you get and the answers are often slightly different than what we do in practice, where it's probably pretty rare that you're going to have an answer that is orthobiologics as the treatment for a tendon problem, yet that's something that we use frequently in clinical practice. So think about your basics first, and we'll go through that when we talk about some of the specific tendon issues. All right, so we're going to start at the shoulder and progress down distally towards the feet. And this is kind of the start of the tour where we're marching through things. And I apologize if there are stops that you want to stay at for longer, but we only have so much time. So as I mentioned at the beginning, the boards will often use vignettes related to tendons to test your anatomy. So understanding origin, insertion, and actions of the tendons and muscles is very important. So if we're talking about the shoulder and the rotator cuff and long-headed biceps tendon, you want to know long-headed biceps tendon runs in the bicipital groove and attaches onto the superior glenoid, and the supraspinatus attaches onto the lesser tuberosity of the humerus. So for example, you could get a vignette that's pointing to, they have long-headed biceps tendinopathy with a positive speeds test. And the question is not going to ask you what tendon is involved. It's going to ask you where that tendon originates. Moving on to looking at the anatomy of the lateral and superior cuff. So the supraspinatus attaches onto the greater tuberosity, as well as the infraspinatus here and teres minor attach onto the greater tuberosity as well. They attach onto different facets. So supraspinatus is primarily on the superior facet. Infraspinatus is on the middle facet with some supraspinatus overlap with the middle facet, and then teres is on the inferior facet. Again, they're probably going to ask you about the actions of these, or impingement with supraspinatus under the acromion. So with rotator cuff and long-headed biceps, typically related to the cuff, patients are going to complain of lateral arm pain with repetitive overhead activity. So the lateral arm over the deltoid is a common referral pattern. With long-headed biceps tendon, their pain is often more anterior. There are several special tests that I'm not going to describe specifically, but that you might see come up as part of a clinical vignette related to the rotator cuff tendons. So empty can, full can, and drop arm are all looking primarily at supraspinatus. External rotation lag sign is a test for infraspinatus. Horn blowers is a test for teres, and lift off bear hug belly press are for subscap, and Yergesons and speeds are for the biceps tendon. If you are unfamiliar with these, I suggest that you Google them and make sure that you're familiar with them before you take boards. From a diagnostic workup, this is more clinically. You may get some x-rays related to the shoulder and chronic changes on the CAQ, but clinically, x-ray can actually be very valuable when thinking about tendinopathies of the rotator cuff, because there are many secondary signs that we can see. So on x-ray, you can see cortical irregularity at the insertion of the cuff tendon. So supraspinatus comes down and inserts on the greater tuberosity here. You can see acetabular, what's called acetabularization of the acromion and a high riding humeral head, which are found with chronic degenerative tears and kind of that end range of the spectrum of tendinopathy. So acetabularization of the acromion is where you almost see this forming a socket to the superior part of the humeral head. So that tells me there's a chronic rotator cuff tear. And then you can also see calcifications, which would indicate a calcific tendinopathy. Ultrasound and MRI can be excellent at evaluating the tendons themselves. In the rotator cuff, evaluation with ultrasound is equivalent to MRI, and the MRI is better if you're also wanting to look into the joint. And clinically, surgeons are probably going to want an MRI before they take someone to surgery. From a treatment standpoint, and this is somewhat the algorithm for most chronic tendon problems, this is very different than an acute tendon tear. So if someone falls, you're worried about a rotator cuff tear acutely, that is a quick MRI and potential referral to a surgeon for repair, provided they have no arthritis. From a chronic rotator cuff or biceps tendon problem, we usually start again with conservative treatment options with activity modification. Physical therapy is important, and you'll want to know the specifics that you would write on the script, including periscapular and rotator cuff muscle strengthening, and then shoulder range of motion. NSAIDs are somewhat falling out of favor in chronic tendinopathies. If you think about the basic science progression of tendon injury that I showed you, once something becomes chronic, there's no longer active inflammation. So plus or minus NSAIDs. Steroid injections are also starting to fall out of favor in tendon problems, because we're learning that the steroid is toxic to the tenocytes, and especially around the shoulder, we now have some data that if you do a steroid injection, it can actually increase the risk of repair or risk of failure after a rotator cuff repair that's happened subsequently. There's some data for shockwave, limited data for platelet-rich plasma, and then needle or device tenotomies can also be treatments short of surgical intervention. All right, moving on to lateral epicondylopathy or tennis elbow and medial epicondylopathy or golfer's elbow. I'm lumping them together here. Most commonly, we deal with tennis elbow in the literature. Most of the studies are on tennis elbow, and we kind of apply all of that to golfer's elbow. So I have another question here. A 53-year-old female smoker who has recently started to play tennis and presents to your clinic with lateral elbow pain. She has tendinous palpation over the lateral epicondyle, and Cosen's test is positive. You diagnose her with lateral epicondylopathy, which most commonly involves the ECRB tendon. You consider trying a counterforce brace, wrist splint at night, relative rest, and enroll her in physical therapy focused on eccentric exercises. In addition to smoking cessation, what other non-invasive recommendations do you make? And I think Andy can pull up the poll. Yeah, perfect. So increase racket string tension above 55 pounds, increase grip size, avoid forehand swings, or you need more information and order an MRI. While people are answering, I will give my test taking tip. If you have a really long vignette, read the last sentence first, because oftentimes the last sentence is going to tell you and clue you into exactly what you need to be paying attention to when you read the vignette. So if you started reading this vignette, you're like, oh, I know this is tennis elbow. And then they tell you the diagnosis. And you're like, oh, okay, well, now what do they want? So reading that last sentence first can be very helpful. So most people said increase in grip size, and you are all correct. So here I highlighted some of the classic findings in lateral epicondylopathy. We will review these in a little bit more detail in subsequent slides. I don't know why this seems to be something that loves to be tested from a biomechanical standpoint, but you can improve the pain related to lateral epicondylopathy by decreasing the string tension and increasing the grip size and avoiding backhand swings. So I am very bad at memorizing things, and I have to think, why is that the case? So if you decrease the string tension when the ball hits the racket, those strings are not allowing the ball to bounce back rapidly with force. So the force is dissipated over a longer amount of time. Therefore, less force is transmitted up the racket into your arm. With grip size, if you have a larger grip, you aren't having to hold quite as tightly, and it's not putting quite as much stress on the tendons. And then backhand swing is using your wrist extensors, which are the tendons that are most commonly involved in the lateral elbow. So if people are having a hard time memorizing those, hopefully that piece of info helps you. So thinking about epicondylopathy, again, going back to anatomy, you might get a question like I just had where it's asking you for a treatment, or they might ask you which tendon is most commonly involved. And for lateral epicondylopathy, it's extensor carpi radialis brevis, followed by extensor digitorum, but extensor digiti minimi and extensor carpi ulnaris also attached to the lateral epicondyle. With medial epicondylopathy, most commonly involved is flexor carpi radialis and then pronator teres, but palmaris longus and flexor carpi ulnaris can also be involved and also originate at the medial epicondyle. And so knowing the muscles and knowing what their action is important. All right, so moving to the next one. For some reason with lateral epicondylopathy, the exam tests and their eponyms are something that tests seem to love. So I always tell people clinically, you just need to be able to understand what tendons are involved, how you test them, and be able to document that from a clinical standpoint. Unfortunately for the boards, they might throw in some of these words. So in that example, I had Cozen's test, which is resisted wrist extension. Maudsley's test is resisted middle finger extension. So that's testing extensor digitorum. Maudsley's test can sometimes be positive if patients have posterior interosseous nerve entrapment, which is on the differential for lateral epicondylopathy. So I've seen that question asked before. Mills test is just passive stretch of the wrist extensors and wrist flexors. And then chair test is where you're basically using the wrist extensors and finger extensors to pick up the back of a chair. And then it's important to keep in mind that epicondylopathy is a clinical diagnosis. Rarely do you need X-ray or more advanced imaging unless you're considering procedures or surgical intervention. From a treatment standpoint, the lateral epicondyle is probably one of the best studied tendons for various treatment options. And so I've listed many of them here that have some data behind them. So modalities with ice heat, ultrasound TENS, ionophoresis, analgesics, NSAIDs, nitroglycerin patches have some data for the treatment of lateral epicondylitis. Physical therapy focused on stretching for lateral common wrist extensors and eccentric strengthening. Like we talked about, the tennis racket modifications, bracing with a counterforce brace. So that is a strap that goes around the forearm. Most commonly, I see patients wearing that around the elbow crease, which is not accurate. You want it to be 2 centimeters or 2 to 4 centimeters distal to the elbow crease. The goal of the counterforce brace is to take the stress off of the proximal tendon and create a different focal point for the muscle so that the proximal tendon can rest. And then a wrist splint just prevents you from extending the wrist and allows that tendon to rest. There's some data for shockwave. As I mentioned, corticosteroid injections have really fallen out of favor here. Platelet-rich plasma is one of the best studied tendon beds for PRP treatment. And then the board answer, this sometimes seems to come up, is the next step is surgery if they failed 6 to 12 months of conservative treatment. And clinically, sometimes that's what we call surgery with a device tenotomy, or for boards, it's going to be complete surgical intervention. All right, staying at the elbow, distal biceps tendinopathy and distal triceps tendinopathy. I have just one slide on each. So distal biceps, we talked about the biceps at the shoulder. It has 2 heads proximally. The long head comes off the superior glenoid. The short head comes off of the coracoid process. They join to attach distally on the radial tuberosity. You could get a question related to the biceps tendon asking where its distal attachment is, and it's the radial tuberosity. Typically, patients complain of deep anterior elbow pain that's worse with supination and elbow flexion. So the biceps contributes a significant amount to supination, but you have several other muscles, such as the brachialis, brachioradialis, that assist with elbow flexion. It's common in manual laborers, and it can often be caused by friction or bony impingement with pronation supination. You can get impingement of the bicipital-radial bursa and the distal biceps between the radius and the ulna. On examination, hook test. This is another named test that sometimes comes up. Hook test is more looking for a complete tear of the distal biceps tendon. You basically take your finger and you try to hook the tendon, and if you can't feel the tendon, then you're worried about rupture. Bicep squeeze test is basically a Thompson test for the biceps, where you squeeze over the muscle belly and should see the elbow flex. Again, more looking for a complete tear, but when we think about biceps, those can be high yield from a test standpoint. Imaging wise, x-rays to rule out bony pathology, but you need an MRI or ultrasound to really evaluate that tendon. And typical treatment is what we often think about clinically: rest, activity modification, physical therapy, and then we can consider injections with platelet-rich plasma. Would avoid steroid here. That is for chronic problems. If someone acutely ruptures their distal biceps, that is a surgical issue. So moving on to distal triceps tendinopathy. So again, knowing your anatomy, triceps has 3 heads. The long head comes off the inferior glenoid, and medial and lateral head come off the humerus and attach to the olecranon. Typically, patients will complain of pain with distal triceps tendon when they're extending their elbow. This is a common location of tendinopathy and calcific tendinopathy and spondyloarthropathy. In patients with spondyloarthropathy, they could also have a concomitant olecranon bursitis with their chronic triceps tendinopathy. On exam, again, modified Thompson tests where you're just squeezing over the muscle belly of the triceps and should see the elbow extend. And then evaluation and treatment are similar to distal biceps, with x-ray to rule out bony pathology, look for enthesophytes, and then MRI or ultrasound give you a better picture of the tendon. And we're kind of doing the same thing here: activity modification therapy, and then PRP or device tenotomies can be considered. Again, that's all talking about tendinopathy. If this is an acute rupture, they need surgical repair quickly. All right, moving down to the wrist. So we're first going to talk about decorvanes, tenosynovitis. And before I talk specifically about decorvanes, we need to look at this picture, and I'm not going to go through all of the compartments, but you should commit them to memory. There will probably be a question on your boards involving one of the dorsal compartments of the wrist, and knowing which tendons are in which compartment can get you that question correct. And they'll probably ask a question related to decorvanes and asking what tendons are where. So decorvanes is insidious onset of pain over the dorsal radial aspect of the wrist, common in patients who are postpartum. It involves the first dorsal compartment or abductor pollicis longus and extensor pollicis brevis. All peanut lovers eat peanut butter. So remember, first dorsal compartment, APL and EPB. The other probably most high yield compartments are second with ECRL and ECRB, and the third with EPL, and you will see why in the subsequent slides. On examination, this is tested with Eichhoff's test or Finkelstein's test. So this is actually Eichhoff's test. Finkelstein's is where the examiner is pulling on the thumb. Basically, both of the tests, the goal is to ulnarly deviate and stretch the tendons of the first dorsal compartment. So as I said at the very, very beginning, when we had the main slide on physical exam, you get pain with resisted strength testing or passive stretch of the involved tendon. And that holds true for pretty much every tendon. Treatment-wise, rest, activity modification, wrist-based thumb spica, and these tendons get irritated and it's more of a tenosynovitis picture. So there's actually this is one area where there's decent data that the steroid helps in the short term, but we don't have a lot of long-term data. All right, intersection syndrome. So I said those compartments were coming back. So intersection syndromes also happen in the dorsal aspect of the wrist. And the thing to remember with intersection syndromes is that everything crosses the second compartment. So the second compartment stays on the bottom. With proximal intersection syndrome, which seems to be most commonly tested, you have the first dorsal compartment coursing over the second. So APL and EPB go over ECRL and ECRB. This is also called Orman's wrist, as it's common in rowers. With distal intersection syndrome, you have the third compartment over the second, so EPL over ECRL and ECRB. And you're probably going to get a question related to this that is asking what tendons are in what compartment. So knowing that anatomy slide from the previous with all the dorsal compartments of the wrist is pretty high yield. All right, we made it through the upper extremity and I'm doing decently well on time. So thank you all for staying with me. So moving on to the Ilios Soaz. The Ilios Soaz consists of the iliacus, which comes off of the pelvic brim, and the psoas comes off the spine, and they attach onto the lesser trochanter of the femur, coursing across the hip joint. So typically people will complain of anterior hip pain or pain when they're trying to take a long stride because that stretches those tendons. It's important to note that there is an Ilios Soaz bursa that sits on top of the acetabular rim, and that communicates with the hip joint. And I've seen that asked in practice questions for the CAQ. So Ilios Soaz bursa communicates with the hip joint. The other thing to keep in mind from a clinical standpoint is that the Ilios Soaz can often be irritated with in the setting of intra-articular pathology. So if someone has problems with the hip joint, they're not moving normally, their range of motion is limited, and they can get subsequent Ilios Soaz issues. So be careful of diagnosing a primary Ilios Soaz complaint when the problem could actually be within the hip joint. On exam, you'll have pain with palpation over the psoas and tightness when stretching the hip flexors. The AMSSM just had an ultrasound case series on snapping Ilios Soaz tendon, and it's important to keep in mind that the Ilios Soaz can be a cause of snapping hip, especially if it's anterior. So I have our video, you can see the Ilios Soaz tendon here. This is lateral, and you'll see that kind of move down. Maybe the video is not coming through great. It's so slow, I don't know why, but yeah, there it just snapped down. So I had to put one ultrasound picture in the talk. From a treatment standpoint, activity modification, physical therapy, stretching and strengthening the hip flexors. You can consider injections, and then surgical lengthening would be the surgical treatment if this is not responding to conservative care and you've ruled out intra-articular pathology. All right, the third question. So a 62-year-old pickleball player presents with 4 months of lateral hip pain that has been gradually worsening to the point where she is no longer walking normally. You analyze her gait and notice that her right hip drops when she is walking. What tendon is pathologic? So right Ilios Soaz, right gluteus minimus, left gluteus maximus, or left gluteus medius. All right, so 62% of people said left gluteus medius, and they are correct. I don't know why boards love the Trendelenburg gait, but it's because it makes you think about multiple steps of where the tendons are attaching and what is happening from a biomechanical standpoint. So if someone is walking and their right hip is what drops, they have weakness in the left lateral hip gluteal musculature, so left gluteus medius or minimus. So you can think about if these muscles are not working, they cannot hold you up straight on your leg. And so then the other side drops as you kind of lean to the side. With Trendelenburg gait, you can also have, you can see that people talk about compensated versus uncompensated gait. So it's uncompensated if the trunk does not move, and it's compensated if the trunk swings to the side to make up for that like hip drop. So we already hit on some of the topics with gluteus medius and minimus tendinopathy. This is a spectrum of peritrochanteric pain syndrome. The thought is that the tendon is the initial problem, and that can lead to bursal irritation. The IT band also courses on top of the gluteal tendons that attach to the greater trochanter that can irritate things as well. The gluteus minimus attaches to the anterior facet of the greater troch, which we can't see here because I have more of a posterior picture. Gluteus medius, which is the large muscle, attaches to the lateral and the superior posterior facets. I'm not sure if that is a really high board relevant topic, but if anyone is learning ultrasound during their fellowship, that is a good pearl to help you distinguish those. Typically, patients will have pain with anything that requires hip abduction and external rotation. And hip abduction is required to be able to stand on a single leg. And even stronger hip abduction is required when you're going up and down stairs. So those are common complaints that patients will have. Pain is in this location over the greater troch. Trendelenburg gait can be seen additionally on examination. From a treatment standpoint, or modifying activities, physical therapy focused on hip and core, hip abductor and core strengthening. There's some data behind shockwave therapy, prolotherapy, PRP, plus or minus steroids. And then kind of this theme is move on to surgery if they're failing 6 to 12 months of non-operative care. I will tell you a lot of surgeons hesitate to do surgery on these tendons. So moving on to hamstring, just one quick slide here. So hamstring tendinopathy, proximal hamstring tendinopathy, I should say, causes pain over the ischial tuberosity. It's common in runners, particularly people who are doing a lot of hills or running on a treadmill. They can have pain with sitting as they sit on the tendons, and then pain with resisted testing for strength of the hamstring. And again, not sure we'll get into the specifics from a board standpoint, but if you're learning ultrasound in your fellowship, there are 2 tendons that come off of the ischial tuberosity. The semimembranosus tendon attaches more laterally, and the semimembranosus muscle will then course medially and come distally to attach. Whereas the conjoint tendon is composed of the tendon of both of the semitendinosus and the biceps femoris muscles. From a tendinopathy standpoint, this is less relevant, but if someone has an acute tear and they tear both of those tendons, that's usually a surgical problem. And if they tear one of the two tendons and it's retracted 2 centimeters, often also a surgical problem. I'm not sure if you'll see questions like that on the CAQ, but those numbers are important to keep in mind, at least clinically, if we're thinking about tears. But trying to focus on tendinopathy and also give you some of the high yield pearls. From a treatment standpoint, the high yield piece is eccentric exercises with physical therapy targeted to the hamstring, as well as core strengthening. So, of course, modifier activity, but physical therapy is really the mainstay of treatment here. Shockwave therapy has some data behind it, and then injections can be used with more limited data. And again, this is talking about proximal hamstring tendinopathy, not hamstring muscle belly issues. So moving on to the adductor tendons, this is often a component of the athletic pubalgia diagnosis. So it's a possible cause of groin pain, common in soccer and hockey players that do repetitive trunk hyperextension or leg hyperabduction. And pain will be increased with active adduction or passive abduction. Treatment is activity modification, physical therapy, and then you can consider injections. From a physical therapy standpoint, we typically think of the Copenhagen protocol, which is just a progression through various degrees of difficulty of adductor exercise strengthening. The Copenhagen protocol is also can be used in injury prevention. So from a clinical standpoint, that's something that you can look at, but also I could see them asking about the components of Copenhagen protocol, and the basic theme there is just you're progressing through various difficulty of adduction of the hip. All right, so now we're moving down to the knee to patellar tendinopathy. I often kind of lump quadriceps tendinopathy into this when I think about it. Often quadriceps tendinopathy occurs in older patients, and patellar tendinopathy is typically in slightly younger patients. Patellar tendinopathy is common in jumping athletes. It's one of the few tendinopathies that's more common in males than females. And it's more common proximally, just distal to the patella, so more in this region rather than distally. If we think back to thinking about pediatrics for a few minutes, they have the bony and tendon combinations with Sinding-Larsen-Johansson syndrome occurring proximally. Oops, sorry. And distally Osgood-Schlatter. But when we're thinking about patellar tendinopathy, it's kind of the same process. They're going to have pain over the patellar tendon. They're going to have pain when they're activating the quadriceps and extending the knee. They will have pain when you stretch the quadriceps. From an imaging standpoint, x-rays can look at the bony pathology. But if you're looking at soft tissue, you would want an ultrasound or an MRI. I really like ultrasound for this tendon. It's very easy and quick to do in clinic. Sometimes on boards, they might start asking you about findings related to tendinopathic tendons. And so this is a picture that illustrates some of them. So this is the patellar tendon with proximal on the right side. So this is your patella. You can see here the proximal tendon is thick and hypoechoic, which are common ultrasound findings of tendinopathy, versus the distal tendon that appears more fibular and hyperechoic. So thick, hypoechoic, loss of typical fibular pattern are consistent with tendinopathy. You can also see hyperemia on Doppler. So keep those ultrasound findings in mind, just in case you get a second level question that asks you not what tendons involved, but what you would see on ultrasound. Treatment, again, eccentric exercises, quad and hamstring stretching, and then a Chopat strap can be used over the tendon in a similar fashion to a counterforce brace for the lateral epicondyle tendons. So popliteal tendinopathy, I have seen maybe one case of this, but I don't know why. The board seemed to love it, and it is on our list of things that can be tested when you look about the topics on the CAQ. So it gets its slide. The big thing, if you remember nothing else about popliteal tendinopathy, remember that it is exacerbated by walking or running downhill. That may get you the question. People complain of posterior lateral knee pain. It's important to understand the anatomy of the popliteus, just like with every tendon. So this is the popliteus muscle here. It runs through the popliteal hiatus of the lateral femur and then comes down to attach on the posterior tibia, just medial and proximal to the origin of the soleus. So people complain of posterior lateral knee pain in this region. You can do Garrick's tests where you're placing them in a frog leg, the patient in a frog leg position and having them palpating just posterior to the LCL and having the patient resist internal tibial rotation. So the other piece of information that you could get asked about the popliteus is its action. So if you know the origin and insertion and you know the anatomy, you should be able to figure out its action. So if the foot is planted on the ground in a closed chain and this muscle contracts, it's going to externally rotate the tibia. Externally rotate the femur. If the foot is not planted on the ground and this muscle contracts, it's going to internally rotate the tibia. So externally rotates the femur in closed chain, internally rotates the tibia in open chain. Might be another question related to popliteal tendon that you could get asked. From a treatment standpoint, rest, activity modification, oral analgesics, functional rehabilitation. You could probably also perform injections, at least in the proximal portion of the tendon if you have a recalcitrant case. All right, moving on to Achilles. And we have our last question. So a 55-year-old female marathon runner presents to clinic with insidious onset posterior ankle pain that worsens with running hills and increasing speed. In-office ultrasound shows thickening and hypoechogenicity of the tendon in the region 2 to 6 centimeters proximal to its insertion. What strengthening protocol do you recommend? So she should avoid strengthening methods so as to not damage the tendon further, progressive eccentric strengthening, strictly concentric strengthening with blood flow restriction therapy, or isotonic followed by isometric strengthening. Awesome. People know the Alfredson protocol. So 93% are correct with the answer of progressive eccentric strengthening. So this has been shown to be a great initial treatment protocol for athletes with mid-substance Achilles. Eccentric load allows for the tendon to remodel, and patients need to be counseled that this causes discomfort or soreness. Clinically, most commonly what I see when people come to me with Achilles tendon problems, and they're like, I've been doing physical therapy. The problem is that they aren't loading it enough because it hurts a teeny tiny bit and they stop. So eccentric exercises, now we're getting a little bit more data about heavy, slow, concentric exercises. I think the boards are probably still lagging a bit behind and are going to ask about eccentric load. I don't think you're going to get a question that asks eccentric load versus heavy, slow, concentric load. So highlights of tendinopathy. From a mid-portion tendinopathy standpoint, there's a watershed region 2 to 6 centimeters proximal to the insertion where the tendon can become thick after overuse and repetitive load. With insertional tendinopathy, this occurs more at the bone tendon interface distally down here. You can also have associated retrocalcaneal bursitis, which retrocalcaneal bursitis sits here, or retro Achilles bursitis sitting here. You can have development of enthesophytes or intratendinous calcification. This is more common in jumping athletes or people wearing poorly fitted shoes. Insertional tendinopathy from a clinical standpoint is often much more challenging to treat. So from a treatment standpoint, I guess I should back up. From an exam standpoint, you're going to have tenderness palpation in the location of either the mid portion or the insertion. Oftentimes, patients have decreased range of motion with dorsiflexion. If you test dorsiflexion with the knee extended, you're testing both the gastroc and soleus flexibility. And if you test dorsiflexion with the knee flexed, you're testing just the soleus flexibility. And then from a special test standpoint, Thompson test is ruling out acute rupture where you squeeze the calf and make sure that the foot plantar flexes. Imaging wise, you can get x-ray to look at the bony pathology, but ultrasound is a quick and easy to use in office, or MRI are better to visualize the tendon. And then from a treatment standpoint, this is similar to other tendons. There's a little bit more data for things in the Achilles, but the mainstay of treatment is progressive, typically eccentric exercises. Nitroglycerin patches have some data, shockwave therapy, orthotics, or a heel lift just to decrease the stress through the tendon for a short period of time. If patients have really severe tendinopathy, immobilization can help things calm down. And then there are multiple procedures with varying degrees of evidence that can be considered clinically for Achilles tendon pathology. I don't think you'll get asked specifically on the boards about any of those, other than the big thing would be avoiding corticosteroid because of the risk of rupture. All right, we're almost there. We have two more. So tibialis posterior tendinopathy. So the tibialis posterior tendon comes and runs posterior to the medial malleolus within the tarsal tunnel and attaches to the plantar aspect of the navicular and medial cuneiform. There's typically pain posterior to the medial malleolus or within the arch. The classic exam finding is the too many toes sign. So that is where the arch has collapsed and the foot is slightly abducted. And you see, when you look at them from behind, you see more toes laterally than the contralateral side. If you ask the patient to go up onto their tiptoes, they lose the ability to supinate and invert when they do a heel raise. And on x-ray, you can see some secondary signs of tibialis posterior tendinopathy, such as medial talar displacement and loss of height of the longitudinal arch when things have become very chronic and the tendon has degenerated. MRI and ultrasound, like we've said before, are better at looking at the tendons. One other clinical pearl is on the differential of tibialis posterior tendinopathy is knot of Henry intersection syndrome. So that occurs in the plantar aspect of the foot where the flexor hallucis longus and flexor digitorum longus cross each other, and you can get a friction syndrome at that location. For back to tibialis posterior tendinopathy treatment, rest, immobilization, arch support, physical therapy, and then avoid steroid in this location due to the risk of rupture. All right, and fibular tendinopathy. So fibularis longus and brevis are in the lateral compartment of the leg. The boards love the leg compartments. So the lateral compartment, fibularis longus and brevis, superficial fibular nerve innervation. The fibularis brevis comes down and attaches to the base of the fifth metatarsal, and the fibularis longus courses to the plantar aspect of the foot, to the base of the medial cuneiform and first metatarsal. And typically patients will complain of pain with eversion or plantar flexion, pain when walking on uneven ground. You can get snapping of the tendons posterior to the lateral malleolus with intersheath subluxation. And you can also get dislocation of these tendons if the perineal retinaculum has been injured. This is a good place where ultrasound can be valuable for dynamic assessment if you're having snapping. The treatment is typically activity modification. You can place a lateral wedge in the shoes. Injections can be considered. If someone has a retinaculum disruption and they're getting dislocations of the tendon, that is an indication for surgical intervention. All right, we made it. So the things that I want you to take away from this is that tendinopathy is a spectrum. The term tendinopathy is a clinical term, talking about pain and dysfunction of the tendon. It does not talk about the specific pathology, which can range from tendinitis, tenosynovitis, tendinosis, calcific tendinosis, and even chronic degenerative tearing. For the boards, keep in mind that anatomy is easily testable. Even clinically, I tell people, if you know what is in the location where someone has pain, what tendon is there, what that tendon's action is, you can figure out what is going on. So understanding the muscle and tendon actions can really, really help you, as well as knowing their origin and insertions. From a chronic tendinopathy standpoint, imaging is often not the best next step. Usually the diagnosis can be made clinically, and you can start with the most conservative treatment options and then progress. So the answer on boards is not surgery in a chronic tendon problem unless they've tried multiple other subsequent interventions prior to the surgery, and it's been 6 to 12 months is kind of the high yield point for that. All right, so I used a couple of board review books and the book on tendinopathy primarily, and then a few other articles as references for this talk. So if you need the deep dive rather than the quick tour, I'd point you to those resources. All right, thank you, and happy to take questions.
First, I just want to say what a great overview. Thank you. You did a very good job with the visual, and that was a lot. I'm going to wait for any questions that come in. Please put them through the chat and I'll bring them up. But a couple of things that I wanted to ask you is, how often do you use ultrasound in your office for tendinopathy issues? Like, is it mostly clinical, or do you just pop the ultrasound all the time?
So I will say if I have trainees with me, I put the ultrasound on probably a little bit more. For me, if it's just me from a clinical standpoint, if something is straightforward and I'm sending them to physical therapy and I'm very confident that that is the problem, then I will make that diagnosis without the ultrasound. If someone's seen multiple people, it's not as straightforward, I'll use the ultrasound. Or if I'm planning any type of procedure, I want to know and understand what the tendon looks like before I talk with the patient about the different procedure options.
So I trained before ultrasound training was in vogue. And although I've learned since, I do find that my practice kind of makes it just flows a lot easier to not to have ultrasound in the office. But if you're thinking about that fibular or perineal, that retinaculum disruption, I love that you brought that up. That's something that's so easy to see on ultrasound in the office. And I think if you have access, it would be a great thing to do. Is there a gold standard for imaging, or, for tendinopathies, or not? I don't know the answer to that.
So I think the classic answer is probably that MRI is still the gold standard, because that is what from an imaging standpoint, that's what we'd still compare ultrasound to in a lot of the studies. However, like the studies on rotator cuff show that ultrasound is equivalent to MRI in diagnosis when compared to surgical findings. And ultrasound has superior spatial resolution to MRI. So you can see the detail of the tendons almost better than MRI. Obviously, the downsides of ultrasound is it's operator dependent. And so that can change things drastically. I think from a diagnosis of a tendinopathy, or any type of MSK issue, we're still saying like the gold standard is some sort of surgery where you open them up and see exactly what is there. From an imaging standpoint, as much as I want to say that it's ultrasound, and I believe ultrasound is phenomenal for tendinopathies, people are always in the literature pointing to MRI as the thing that everything's compared to. I think that's going to shift, and it kind of is. But the surgeons make the rules and they know MRI.
So a couple of points. There was a question that I definitely want to get to, but I think it might bring some discussion. So I just want to say quickly, in the office, you talk about a lot throughout this whole thing about knowing the origin and the insertion of the tendons. I think I want the fellows to recognize that it's okay to bring up images as you're describing stuff to the patients, and it makes you also remember the origin and the insertion. So we don't have the privilege of going into somebody's body all the time and seeing the anatomy. And so anytime that you can see a visual, anytime you can look up the imaging, or you can do an ultrasound and you see the imaging, it helps you remember. Because when you're checking like someone's perineal tendon, you want to activate that tendon, you want to push on the base of the fifth, you want to follow it up. So just remember that, use the things that are available to you, whether it's ultrasound or just even Google imaging. But so there's a question that somebody asked about, does hormone therapy increase risk of tendinopathy or just a lack of hormones? And also, what about menopause? Does it increase stiffness in tendons or increase injury?
Yeah. So aging in general increases tendon stiffness and injury risk. So we think about people in that spectrum of life. The hormone therapies in and of themselves can increase risk for tendinopathy, from my understanding. I will say I'm not an expert in that area of the specific changes of menopause, but as we age, everything gets stiffer and tendons are at higher risk of injury.
So I know for a fact that you're not an expert in that, and that is because no one is. It has not been studied. We do not look at female versus male enough. So most of the studies have been done have either been of a mixed gender or extrapolated from male studies. So I love that question, because really the answer is we need to study it more and more. And Dr. Schroeder, I know, is really involved in and interested in looking more at the female athletes. So I have no doubt that you will learn more about that in your future. One thing that I listened to that you said, and I think this is a common question from patients, and I'm not sure what the answer is how much pain is too much pain with physical therapy? Um, I'm going to throw out there that everyone's pain tolerance is a little bit different, but what should you be counseling your patients on with what's a normal pain to have with
Yeah.
therapy?
Yeah, so I agree with you. Everyone's pain tolerance is a little bit different. I typically tell them that I don't want them to be like gritting their teeth or feeling like they're like telling themselves I have to push through this pain to get through. And what I also don't want, which is hard to tell at the time of the exercise, what I don't want them to be is more sore after the therapy is done that doesn't improve by the next day. So sometimes people push it too hard in therapy unknowingly. They don't feel that bad, but then they're really sore for a day or two. I try to describe to people about like, imagine you are going to the gym for the first time. Like you want to start small enough that you feel a little bit sore and feel like you did a workout, but you don't want to go to the gym and, run 30 minutes on the treadmill when you haven't run in 5 years. So you're not going to go to your physical therapy session and do 150 calf raises when you haven't done a calf raise in 5 years. So typically I encourage people at the beginning to start gradually, because what I don't want is them to go to therapy and say, oh, it made me hurt worse, and then totally stop. So I always counsel them that they're going to be like ups and downs. And as long as the trajectory is things get a little bit more sore, but they get better and we're overall gradually improving, it's okay if they have like some little blips, because there is trial and error. But I don't want them to sit there and feel like they need to suck it up and like get through, like they're at the gym with a personal trainer who's like cheering them on to like bench as much as possible. It's kind of my little spiel.
Well, all right. I think that's a good ending point. And you did a great job. Thank you so much for all the visuals and everything. That I think is a really good overview. If there's no other questions, I think that we can sort of end that meeting there.
Awesome. Thank you so much for having me.
Thank you. All right. Have a great night, everyone.